Welcome. Today in this explainer, we're tackling something that doesn't get talked about nearly enough, but is absolutely critical in community care, managing adult fecal impaction. Our goal today? Simple. We're going to map out a structured, empathetic, and above all, safe pathway to treat this condition and keep our patients out of the hospital whenever we safely can.
So, here's how we're going to climb the clinical ladder today. First up, assessment and red flags. Then oral and rectal interventions. Third, emergency care and surgery. Fourth, frail elderly surgical considerations. And finally, prevention and patient communication. Let's dive in.
Section 1. Assessment and red flags. Establishing the baseline.
Okay, so to establish that baseline, a digital rectal examination, or DRE, is usually our starting point. Now, right off the bat, this absolutely must be done by a nurse fully competent in the procedure. But look, before you even think about gloving up, you have to check their history. You need to rule out any mechanical obstructions, things like a previous volvulus. Only once you've cleared that can you safely proceed to palpate for that hard, impacted fecal mass. Let's be real for a second. These procedures are highly invasive. They're distressing for our patients, so how we talk to them is just as crucial as our clinical skills. Here's a really compassionate script you can use. I know this examination can be uncomfortable and cause anxiety, but it is a vital step to find out exactly what is causing your pain so we can safely relieve it. Using that specific framing is a fantastic way to bring their anxiety down and build trust right from the start.
Now, during this whole assessment, your primary focus has to be safety. You need to be hypervigilant for what we call escalation red flags. If you feel a rectal or abdominal mass, or if the patient has unexplained weight loss, iron deficiency anemia, rectal bleeding, a sudden change in bowel habits, or unexplained abdominal pain, you stop right there. These are critical signs that mandate an immediate 2-week wait referral to colorectal specialists, no exceptions.
And speaking of stopping, there's another major hard stop you need to be aware of: autonomic dysreflexia. If you have a patient with a spinal cord injury at the T6 level or above, fecal loading, and frankly the rectal interventions we use to clear it, can actually trigger a potentially life-threatening cardiovascular reaction. For these specific folks, standard manual interventions are incredibly dangerous and require highly specialized management.
Section 2. Oral and rectal interventions. The step-by-step treatment protocol.
All right, so you've safely cleared all the red flags. What's next? It's time to start treatment. The Shropshire Community Health NHS Trust actually put together this fantastic cognitive map for us. As you can see, it guides you step by step, from assessing the stool to trying first-line oral therapies, and then, if those aren't cutting it or we need fast relief, dropping down into second-line rectal interventions.
Let's break down that medication ladder. Your first-line defense is oral macrogol. If the stool gets soft but still isn't passing, you go ahead and add a stimulant laxative. But what if the oral meds are just taking way too long or your patient is in severe discomfort? That's when you step up to second-line treatments: digital removal, suppositories like bisacodyl or glycerin, and microenemas. And if that still doesn't do the trick, we move to the third line: larger retention enemas using sodium phosphate or arachis oil.
But wait, before you administer those third-line medications, you absolutely must check for contraindications. Patient safety is literally on the line here. Arachis oil enemas? Strictly prohibited if your patient has any history of a peanut hypersensitivity. It can cause a severe allergic reaction. Also, Dantron is highly restricted. It's only indicated for treating constipation in terminally ill patients, so it is completely off the table for general use.
When we have to escalate to manual disimpaction, patients often experience a really confusing symptom: overflow diarrhea. They literally think they have diarrhea, not a massive blockage. So here's how you can gently explain it to them. To make you comfortable, we need to gently remove the blockage. You may experience overflow diarrhea, liquid leaking around the blockage, before the impaction is fully cleared. That sets their expectations perfectly, so they understand why the procedure is totally necessary for their comfort.
Section 3. Emergency care and surgery. Recognizing the hospital off-ramps.
Look, despite our absolute best efforts in the community setting, sometimes conservative management just fails. When that happens, you need to be on high alert for styrocoral colitis, which can lead to a catastrophic bowel perforation if your patient suddenly develops severe abdominal distension, escalating pain, a fever, or peritoneal signs like rebound tenderness, guarding, or rigidity. This is an absolute emergency. Get them transferred to the ED immediately.
Once that patient hits the hospital doors, the absolute top priority is an abdominal CT scan.
The hospital team is going to be looking for the impaction itself, sure, but also for colonic dilation greater than 6 centimeters, wall thickening over 3 millimeters, and pericolonic fat stranding. Those are the telltale signs of localized ischemia and inflammatory injury. That's the data they need to guide emergency operative management before a perforation happens.
Section 4. Frail elderly surgical considerations. Prioritizing reversible options.
It's a sad reality, but fecal impaction disproportionately hits the elderly. And for frail older patients with a bunch of other health issues, major abdominal surgery is incredibly dangerous. So, when surgery is the only option left for these vulnerable patients, we follow a very strict algorithm to minimize harm. Step 1 is always the safest first move: controlled manual evacuation in the operating room under anesthesia. If that fails, step 2 is a defunctioning loop ileostomy. And only if both of those fail do we ever even consider step 3, a major resection or colectomy. There's a massive difference between those two surgical backups. A defunctioning loop ileostomy just temporarily diverts the feces. It decompresses the colon, and the best part? It's fully reversible. A major resection, on the other hand, means permanent anatomical changes and usually very poor outcomes for the frail elderly. So for our most vulnerable patients, that reversible route is vastly preferred as a last resort.
Section 5. Prevention and patient communication. Stopping the recurrence cycle.
At the end of the day, the absolute best way to treat fecal impaction is to just prevent it from happening in the first place. It all boils down to the long-term prevention triad: hydration, fiber, and mobility. I know, they sound super basic, right? But their daily integration is literally the cure. As clinicians, we have to constantly remind our patients and their families that sitting around too much, not eating enough fiber, and skimping on water are exactly what causes these hard fecalomas to form. We also have to be proactive about medications, especially opioids, which we know just completely shut down gut motility. If you're starting a patient on long-term opioids, standard stool softeners alone aren't going to cut it. You need a dedicated prophylaxis strategy. You've got to proactively prescribe a stimulant laxative, like Senna or Bisacodal, with a softener, or use a daily osmotic laxative right from day one. Don't wait for the problem to start.
Well, we have covered a ton of ground today, climbing all the way from simple oral laxatives up to emergency major surgery. But I want to leave you with one final, real question to think about. Are your community protocols strong enough to stop the impaction cycle before the very first red flag even appears? By catching the signs early, optimizing those meds, and communicating effectively with our patients, we can avoid those scary emergency escalations entirely. Thanks so much for joining me on this explainer.